and we'll just deal with them as they come. So today's talk is going to be on hormone health, okay? And this talk is not only going to be directed specifically at females, for all the men in the room, but we will be talking about some aspects of testosterone, and briefly touching upon like erectile dysfunction. It's a real thing, and men don't want to talk about it, and it's something that should at least be addressed. But that being said, a lot of it will be directed at females because they're females and their hormonal rhythm is so much more complex than guys. And we will be talking about that a little bit as well and giving examples as to that. And again, I wanted to stress before I got into my spiel and start forgetting other aspects, this is a conversation not only for cycling women, but women who are transitioning or perimenopause into menopause or postmenopausal. So this is a conversation that is applicable to all women at different cycles and stages of their life, okay? So really important to keep that in mind. And I really have a strong belief, everyone can hear me if I'm over here, okay? And I really have a belief that no matter what stage you are in your cycle, that we should be supporting at some degree some type of hormone, whether it is progesterone, estrogen, even testosterone. First and foremost, get and know where we're at and not just randomly progesterone, testosterone, estrogen, okay? Really is a standpoint where I come from because as you're going to see, estrogen, progesterone, testosterone is so crucial to normal hormonal rhythm and helps with a lot of potential symptoms or preventing potential symptoms when these levels drop really low. I was watching a great video on a well-known gynecologist. His name is Dr. Uzi Reese. He's a big wig out in California, sees all the superstars, and he made a comment, and he goes, it's not just coincidental that when women go through menopause, that weight starts to really come on. And he goes into talking about the connection with estrogen and estrogen dropping out and weight accumulating in response to that. And he talks about how we're so fearful of estrogen because its relation with potential breast cancer. And we'll talk about that in a cursory topic in regards to that some of the data out there isn't so cut and dry that, oh, you take estrogen, you're going to get breast cancer, right? There's genetic pieces, and there's actually some research even showing and supporting that that might not necessarily be true. But just like anything, you could find one end to debate with research, and you can find the other end to debate with research. So I want to make sure that, there definitely is some research on the other end. So you always have to be cautious. You always have to do your due diligence, making sure you're checking their genetics, make sure they're not HER2 positive, make sure they're not carrying a BRCA gene, making sure they don't have any family lineage with cancer in the family, right? So that's a priority. And I'm already off on a tangent, but let's get back into this here. So we're going to go over hormone health. We're going to talk about some normal hormonal rhythm, what that looks like, why fat is so essential for hormones. We'll be talking about adrenals, very, very cursory overview. We'll be talking about the thyroid, and we'll be giving you some good tips. That's my goal. You've taken the time on your busy evening to come here and listen. I want you to leave with some type of actionable item that you can go home and implement tomorrow. So that's my goal with all my conversations, okay? And again, I want to thank you for being here. I know your evenings are very busy, and thank you for giving me, some of your time this evening. So, estrogen. Everyone knows about estrogen. So we have three types of estrogens. So when we talk about In my office, when we look at your estrogens, we look at your total estrogens, estrone, E2, estradiol, which is your most active hormone during your female cycling years. That is the most important hormone, E2, estradiol. And then we have E3, which is estriol. And typically, when you're using estrogen, you're never typically given one. It's compounded with either what's called a biest or a triest. And it's basically a percentage of the two. Usually like a biest is an 80-20, 80-20 estradiol, 80 estradiol, 20% estriol, or a triest up into 3. So a percentage of estriol, a percentage of estradiol, a percentage of estrone. Then we talked about here, so menopause. So once you hit menopause, it's not that you're done producing estrogen. Menopause isn't hit, it's like, oh, estrogen's all done. No, that's incorrect. Estrogen will be produced from your adipose tissue. So our fat is like a little organ of itself, right? Our liver, our kidneys, and the big one is our adrenal glands. Your adrenals will produce the majority of your estrogen, progesterone, and testosterone once you are done cycling, once you are done having your menses, okay? I just thought this would be funny, maybe not, but the picture, my typical PMS symptoms, eat whole food all day, cry about it, get mad at all the people, cry about it again and repeat, right? So we kind of connect, the reason why I put that is we connect estrogen as that, what are you doing to my body? Why am I feeling so horrible? And I just want to reframe that maybe it's not always that horrible hormone, right? It is really crucial and really important that we manage and get estrogen at a nice normal hormonal rhythm. You can see some other aspects that estrogen does. Improves, very important for eye quality, eye health. Very important for cardiovascular function. And what the big term that everyone loves, it's helpful with weight loss, okay? Now, can you get water retention with taking estrogen? Yes, you will get water retention, which will therefore make you think that we're not losing weight, my pants feel a little bit tighter. But if you pair that with progesterone helps to pull water out of the tissues, okay? So just keep that in mind. If you're taking estrogen, you will get water retention. But if you're doing it correctly, you should be taking at least a little bit of progesterone, which will take some of that fluid out of the cell, okay? So low estrogen and weight gain, okay? So you guys are going to understand all of this. When estrogen drops, you lose more brown fat. So when your estrogen is low, your brown fat starts to go bye-bye. Your brown fat is what is metabolically active. So the two of the most active tissues in your body, muscle and brown fat, they burn through calories like crazy. So when our estrogen drops, we lose our brown fat. Now I'm expecting all of you to know this right away. Ghrelin increases. CCK and GLP-1 goes down. You increase adiponectin, you become insulin and leptin resistant. I know you all know that right now, right? You're like, what did he just say, right? So low estrogen and weight gain. It takes more food to feel full. That is leptin resistance. So when estrogen goes low, we get leptin resistance, which means it makes you have to eat more food to feel full. So now we start over-consuming calories, okay? We're hungry more frequently. Our ghrelin increases. This is a hormone that's secreted that tells you that you are hungry. How I always remember this in my brain, ghrelin makes your tummy growling, right? I don't know why, but that's how I always remember it. So So now not only do we start overeating more because we're leptin resistant, but we're hungry more frequently, okay? Our blood sugar increases easier, okay? So this is where some of these fancy terms come in. A decrease in CCK, a decrease in GLP-1, and an increase of adiponectin. All of these markers mean that we are able to increase our blood sugar easier, okay? When blood sugar increases, that means insulin will increase as well. Insulin is a fat storage hormone. If your insulin is high, you can do all the exercise till the cows come home, you're not losing weight. I can promise you that, okay? Now when we get into bodybuilding, certain men want to talk about putting on muscle. Insulin is important for gaining muscle, but that gets into the minutiae in the fine details. But for generality, high sugar equates to high insulin, which means fat storage. You're going to retain your fat. You will not lose fat, okay? And again, that all starts with increasing blood sugar. Our blood sugar coming, okay? And I kind of already talked about this. We as fat easier. That's insulin resistance. That's what insulin resistance means, right? So again, remember, sugar comes up, insulin comes up, and then we store fat. But if we're insulin resistant, this is how I tell when we become insulin resistant, when you knock at the door, you don't hear it. So now I have to really start banging at the door to get attention. And that's the same thing with our cells. Our receptors become deaf to insulin. So now we need a big bolus of insulin to be released, and now we have way too much insulin circulating in our blood, and we just start storing, right? So you can see how that can become a vicious cycle, okay? So I was up late Monday night trying to say, okay, how can I explain this super simple? I hope I did a good job, but again, it takes more food to feel full. We are hungry more frequently. Our blood sugar increases easier, and we store fat easier when our when our estrogen is low. Okay? I hope I did a good job with that. Okay, progesterone. This is another, I always call this the beautiful hormone, because progesterone is just, it makes you feel nice and relaxed. It binds to our GABA chloride channels in our brain, which help us to sleep. It makes us feel good. It's just that calming hormone until probably with some of you women are thinking, yeah, until you're on the back half of your cycle and I'm just raging incredibly hard right now because your progesterone's dropping out, right? So this is something that's really important because you'll see in just a minute what the rhythm should look like. And when we're getting, a lot of women will say, yeah, a week before my menses, my period, I have cramping, I'm more irritable, I'm just not in a good place. That's because your progesterone is dropping out when it should be sustained, okay? Or you're getting a dip in progesterone and then it comes back up. So what I want to see with my patients is a nice, smooth progesterone curve in the luteal phase, which is the back half of your cycle, all right? But progesterone, everyone loves it. It improves hair and skin quality. Who doesn't like good hair and good skin, right? As I already talked about, it opens the GABA chloride channel in the brain. So that's the brain that helps to get, that's a receptor that helps to get you to relax. So some women, when they take their progesterone at night, they sleep like babies because it helps, very helpful with that action. And then we want to at least mention that we want to have a healthy ratio to progesterone and estrogen. So we typically like to see a 25-to-1 ratio for progesterone to estrogen. So that's really important to talk about. And like I already mentioned, we do not want this hormone to drop during the luteal phase. That's the back half of your cycle. Okay? Okay, testosterone, right? This gives us muscles, right? So women, ladies, please, 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 if you take testosterone, you're not going to get big like a man does. The physiology is just different, okay? It interacts differently than when a man takes testosterone compared to when a woman takes testosterone, okay? But what I will tell you is women come to me, my sex drive is low, my libido is low. Well, I can tell you for certain testosterone will help. Testosterone will help your libido. So that's a really nice trick. Or you can do DHEA. DHEA is another really nice way to try to improve libido. Sometimes women will say, Dr. Ross, my libido was too good. You need to stop. We gotta back this down. But really important. Maintain. So obviously everyone knows testosterone is maintaining. Remember, one of our most metabolically active tissues is muscle. We want that. We want muscle to help us to burn calories, right? While you're sitting there, you're burning calories. But if you have more muscle, you'll burn those calories. It obviously increases energy, right? It improves fat distribution, okay? Again, because it's metabolically active. A lot of people don't realize that we have almost as much, if not more, testosterone receptors in the brain than men do have in the testes. So cognition can improve significantly when taking testosterone. Okay? And then, again, for men, it improves red blood cell production. So it improves blood flow, right? When we talk about ED, erectile dysfunction, that is a blood flow issue. That is a blood flow issue. And it helps with spermatogenesis, the production of sperm. So if a male is having difficulty with conception, you can do testosterone. You just have to be careful because if you do too much testosterone, you'll shut down the loop. You'll shut down the feedback loop from the brain, from the testicles to the brain. The testicles will say to the brain, producing it, and then you'll stop producing testosterone naturally. So you have to be careful with that. Okay, so ladies, this is your cycle. I bet you're very familiar with it. Like, yeah, I know that haunts me, right? Well, maybe not. But in the first half of your cycle should typically be. Now it depends. I always ask. First started cycling. How many days was your cycle? How many days do you remember? Some will say, 28 days. Typically, the average woman cycles for 28 days. So, day 1 to 4 to 5, typically 1 to 4 is menses, is bleeding. Then days 1 to 14 is typically the follicular phase, and that's where estrogen starts to rise. You can see that's the blue portion right up here, and that's the first half of your cycle. Estrogen should be higher. Okay, then we get into ovulation, which should be somewhere around day 14, 15, 16, and then you can see there we have a surge in luteinizing hormone and a surge of estrogen. Okay? And estrogen helps with libido as well. Estrogen helps with libido because innately, primalistically, this is your body tells you, whether you realize it or not, time to conceive. Time to conceive. Day 14, 15, 16, time to conceive. So that's when it increases because you're starting to release your follicle now. You're starting to release the egg. And the best, obviously, everyone knows this, best chances of conception are during ovulation, right? So another aspect where estrogen is beneficial for libido, not just testosterone. But you can see you have that spike of LH, spike of estrogen, and then we get back into the second half. So typically days 16 to 28. Again, some females might say, yeah, I've always had a 32-day cycle since day one. There's nothing wrong with that. That's fine. I've had patients tell me they've had 36-day cycles. Now we're getting, I still try to work to bring that down, because then we can get a lot of polycystic ovarian or endometriosis, because the lining of the uterus is just building up too long, and that patient was not able to shed their lining, all of it enough, so we had endometrial lining building up, which was creating some issues. But again, second half of the cycle is your progesterone. That red there, that's your progesterone. That's how we want to see it, this nice, undulating, smooth curve. And where we get the issues is when this back half here drops too quickly. That's when we get all of the issues, and we get all of the PMS and the cramps and irritability and mood swings and food cravings and headaches and sleep issues, dry skin, list goes on, right? So that's one area of concern. The other area of concern is that we don't hit ovulation, or estrogen is too low on the front half, right? Also, another area of concern that I'm keeping an eye out is that maybe your ovulation is shifted. Maybe you're ovulating around day 19. I've seen it before. Maybe you're ovulating around day 7. Maybe you're having 2 ovulations during one cycle. I've seen it before. Try conceiving when you have 2 ovulations during a cycle. It's not going to happen. It's not going to happen. So you can see all the potential issues that women can have, right? So again, I can get a little bit calm, because just women it's a symphony. It's just so many things need to be going right at the same time. Everyone needs to be on cue. One thing goes off, it sounds like nails on a chalkboard. Same thing with a cycle. Same thing, okay? So progesterone, estrogen in the first half. Then we have luteinizing hormone, which signals ovulation. Then we have follicle stimulating in the first half. Then we have luteinizing hormone, which stimulates estrogen. And then we have progesterone in the second half in your luteal phase. I'm done beating that one. I think we're probably our heads scratching a little bit. But it's really important. Yeah, go ahead, Soleil.
I'm curious, how is it possible not to ovulate and still have a period? I've heard of that, but why would that happen?
Yeah. So it's possible because you might not, there's a couple things. Your estrogen might not have gone up high enough to signal ovulation, or your luteinizing hormone did not go up high enough to signal ovulation. So think of it as this. Think of it as you're driving a car, you drove right past your exit, but you keep on driving. We keep on signaling the other hormones. So you don't technically need to have your menses and ovulate. You have to hit a certain number in your estrogen to ovulate. But it doesn't mean the cycle stops completely. The cycle will keep on going. It'll say, we get to day 14, our estrogen just wasn't high enough, our luteinizing hormone wasn't high enough, so we didn't ovulate, but we're going to keep on going. Day 17, 16, and progesterone's going to come up, and what triggers your menses is that back half, that drop of progesterone. As progesterone drops, that's when you shed the uterine lining, okay? So this is how I always think. Estrogen builds life. Estrogen, you build, okay? Progesterone, you sustain. That's how you sustain the pregnancy, is progesterone. But as soon as progesterone drops, we start back over. Shed the uterine lining and start all back over.
That was very helpful. Thank you.
Yep. Okay, this is for the men. This is funny. This is men normal hormonal rhythm. that was a joke. It's not necessarily true, but it's somewhat true. Like, we just talked, for like 20 minutes about female rhythm? Meh, that's men. No, but it's not necessarily true. Not necessarily true, okay? So the top half here is growth hormone secretion for women, healthy women. You can see all the peaks, right? You can kind of get a feel for that there is a rhythm and that there is some change in growth hormone at different times of the day, right? And you can see here, this is a healthy male with growth hormone secretion. So is there as many peaks? No. But is there peaks to signal that there is some type of rhythm? Yes. So ladies, when your husband's having a bad day, you can turn to him and go, honey, you must be cycling right now. I'm sorry. You must be on your menses. You must be cycling. So they do have a rhythm. Men have a rhythm, okay? So we do want to recognize that, all right? Okay, so this is all the hormones. We're going to talk about all of this, okay? No, we're not. We're not. But you can see how complex it can get, right? So you can get an understanding that it isn't as simple as here's progesterone, here's estrogen, here's testosterone, okay? I expect everyone to memorize that. There will be a pop quiz on that. All right, so we're going to briefly talk about the adrenal glands. If you remember, we talked about once we're done with cycling, once you have hit menopause, your adrenal glands take over and produce the estrogen, progesterone, testosterone. Okay? So you can see here, and again, Dr. Reese talks about one of the biggest mistakes that he sees in all of his OBGYN cohorts is that they don't even address the adrenal glands or the thyroid. We're going to talk about the thyroid as well. But those are hormones as well. They need to be addressed. But you can see here, at the very top here, what's the very first thing in the top right, your left corner? Cholesterol, fat. Fat is so crucial. If you deprive yourself of healthy fat and you get your total cholesterol, cardiologists, they want to see 0. Yes, we got your cholesterol to 10. How are you going to produce hormones? You're not. So it's just a little bit of food for thought that we don't want to be, so single-minded that we want cholesterol. It's healthy for our brain. It's healthy for some of our phospholipid bilayers. We need good fat. Okay? We need a good fat to even start to make hormones. And then you can see how the adrenal glands, so DHEA, that's a hormone produced by the adrenal gland. Cortisol, that's a hormone produced by the adrenal gland. Basically aldosterone, that's another hormone produced by the adrenal gland. But in order to make these, look where they need to come from. Progesterone. In order to make your testosterone, look where it needs to come from. DHEA, that's an adrenal hormone, right? So you can see how intertwined they are, right? They're not these separate systems. They communicate to one another. So if we have, you can probably answer this, if we have our hormones aren't working optimally, you think our adrenal glands are going to be working optimally? No. And you can say vice versa. Do you think if your adrenal glands aren't working optimally, do you think your sex hormones are going to be working optimally? No, they're tied together. So I won't beat this, but I just wanted to make sure we at least touched upon it, right? I feel like I would have been robbing you if I didn't. And then thyroid, really important. So this is something that is missed as well, right? So basically the thyroid, your adrenal glands, your sex hormones, they run off the same circuitry, okay? All the signaling starts in the hypothalamus. Then it goes to the pituitary, right? And then they go to the separate organ systems, the ovaries, the testes, the adrenals, but they do share the same circuitry. So you want to make sure basically that your thyroid is is looked at, is assessed, right? But thyroid is important, very, very important. And then this isn't a thyroid talk, so I'm not going to go into all the details of the thyroid. But if you're assessing your thyroid, please look at more than just your TSH. Please look at your free T3, your free T4, your T4 total, T3 total, TSH, and look at your antibodies. Make sure you don't have Hashimoto's. And if anyone has questions, you can bring them up afterwards. I would love to talk about the thyroid. Okay, I had to at least mention this. People don't want to address stress. Stress is a real thing, right? Now, I get it all the time. Well, why are my hormones so off? Why are my adrenals off? How did this happen to me? Well, you've got 3 kids. They all got to get to sports. You got to take care of your profession. You got to make sure that we have life, right? We have life. Or are you fighting the tiger? Are you in that stress response? That's going to affect the adrenal glands, which will therefore affect your sex hormones, which therefore will affect your thyroid, right? I just love this. This is something that just, succinct, or I connect with. What a great day. I spent the morning burning bridges and the afternoon putting out fires. Like, isn't that life? So just the aspect of, let's pay homage to stress. Let's realize it does affect our physiology, and if you don't have a strategy already, please go home, think of a strategy how to cope with stress appropriately instead of reaching for food, to comfort you. Okay. All right. So we just do some basic testing here. This is nothing too exciting, but we look at your pregnenolone. We make sure we look at your progesterone. We make sure we look at your cortisol when I'm assessing hormone function, okay? We make sure we look at your DHEA sulfate, okay? So this is an adrenal hormone. Obviously, progesterone is a sex hormone. But these are things that we have to look at. Okay? And I can remember this case. Her pregnenolone was a 33. I want that at 60. So that was low. I can already tell her are low. And if you remember, 2 things you need in order to make adrenal hormones and sex hormones are cholesterol, and then what's the next thing? Pregnenolone. So if you have low pregnenolone, how in the world are you going to make all those other hormones? So we look at the pregnenolone, we looked at the progesterone, the cortisol, the DHEA. We look at your luteinizing hormone, your follicle stimulating hormone. So those are the hormones that are from basically the brain, that signal to the brain to the ovaries to produce your estrogen and progesterone. Okay? We look at your estradiol. Is true or false? I'm going to see if you're paying attention. True or false? Estradiol is not the most active hormone during your cycling years. True or false? It is not the most active hormone during your cycling years. Correct. It's false, right? E2, estradiol. E2 is your most active hormone, your most active estrogen during cycling years. And then we look at, I don't have it on here, but we look at your total estrogen. We can also look at sex hormone binding globulin. For women who are trying to conceive, I always make sure you look at your AMH, your anti-Mullerian hormone. That looks at basically egg viability. And then this is a great test. So we look at, I don't run it as much as I should anymore, and this is a nice reminder to make sure I run this. It's your entire cycle patterned out. So you can do a urine test every other day throughout your entire cycle and actually get your hormonal rhythm. And it gives us great data because we can say, oh, it looks like you're dropping, you're dropping around day 20. We need to increase your progesterone around day 20. Up, it looks like your progesterone is completely shifted. So we need to try and push your progesterone later in your cycle. And we can do the same for estrogen. It's just estrogen on top here. Because you can see, remember I talked about earlier how your ovulation can be shifted? This person was ovulating around day 10, around day 8, day 10. That female was ovulating. She wasn't even close. If she's thinking, oh, I ovulated around day 14, day 15, she's way off. So really helpful. And then this, I know it's hard to see, I apologize, but this gives you, these are your 3 estrogens here. This shows you the production of your 3 estrogens and then how you break down those estrogens. So it shows your estrogen metabolites. Because again, estrogen can be a cancer risk, right? So if you're not breaking down your estrogen appropriately and you're breaking it down into, it is 2, 4, 16. If you're breaking it down into the 16, I always forget. It's the 16, that creates DNA damage and can lead to cancer. So looking at estrogen metabolites is really, really important. But this is a great test. Just the only thing is, it's not the most convenient because you got to go through your entire cycle and then send it out to the lab and then you wait for it to come back. So you're waiting for a little bit when you're like, I wanted to get information now. But I try to reinforce my patients, be patient. It's great information. It will help us significantly. Okay, too much of a good thing, right? So we can have, again, too much estrogen, too much progesterone. We talked about we want a nice ratio of 25 to 1, being 25 progesterone to 1 estrogen. That's a healthy ratio. If we have high estrogen, that can lead to polycystic ovarian syndrome. It could lead to endometriosis, potentially cancer, as we talked about with estrogen. If we have really high progesterone for long periods of time, we could have, again, possibly some endometriosis, but a thickening of the endometrial lining, mood swings, depression, breast nodules, water retention. As I drink some water, my throat's drying out. Give me 1 second. Thank you. Water retention. So it's just to bring back like the aspect of, we're not going to go 100% to the floor with this. We want to make sure we're assessing and that we're moving the needle appropriately here. Okay. Okay. Important to talk about bioidentical versus non-bioidentical, or I would like to say chemical. And then some people would say, well, aren't they all chemical? So the big thing here is your bioidentical is you can get plant-based hormones. And the major aspect here, it's the same molecular structure that naturally occurs in women. Excuse me. And typically the ones that we use are made from wild yam. And the main aspect is that it does not need to be conjugated by the liver. Big word that means broken down. It does not need to be broken down by the liver to make the hormone active. And it's that conjugation process which creates harmful metabolites. Just think things that can damage the body, right? Hence, possible increased risk to cancer. So you can see some examples of pharmaceutical bioidenticals. So prometrium, estrase. We work with a compounding pharmacy that compounds our hormones. So we can actually work with a pharmacy that can actually compound them, which is really nice, and that's bioidentical. Non-bioidentical. So it's not chemically identical. So the progesterone doesn't look exactly, or the estrogen doesn't look, or testosterone doesn't look exactly like your molecule in your body. maybe it has like a double bond, or maybe there's a kink in it when, to the right when it should have been kinked to the left. And what the body does is it conjugates it, breaks it down, so then it now looks like the hormone that it should look like. But again, during that conjugation process, which just means breaks down, it creates like trash, creates a harmful metabolite. Okay, and then, so again, I put it there in capital letters. It needs to be conjugated. Okay, and it can create. We talked about this. So it can even change the function of receptors. So a receptor that looks like a Y, now it looks like an X. So when that molecule, say, a Y and a Y, a letter Y and a letter Y go together, now that other molecule that was floating around, when it sees that receptor, it doesn't recognize it as a Y receptor. So you can actually change the function of receptors. And then higher levels than expected. So you don't know how effectively you're going to conjugate. So now maybe you over-conjugated and now we have too much hormone, right? So really important that we talked about this, because this is a big sticking point with, well, is it natural? Is it a chemical? So important to talk about. And then just some examples of non-bioidenticals. So Premarin, Provera, Depo-Provera, Senestin, Enjuva, and Prempro. Okay. Oral contraceptives. So another thing that I just wanted to mention. It can take, so you can take low dose of progesterone in the luteal phase to help with PMS symptoms, because one of the big things with contraceptive is most women take it because my cycle has been horrible, right? I have, the worst menses. I have, really bad bleeding. But if you support that progesterone in your second half of the cycle, support that progesterone, you can help a lot of those PMS-like symptoms, right? And then just coming off oral contraceptive can result in low estrogen and altered progesterone. So coming off of that, it can create some issues, right? Remember, low estrogen, all the issues with weight gain, right? And then detoxing is important to clear some of these synthetic hormones, because these oral contraceptives are typically synthetic, right? But I can go more into that if someone wants more conversation. I'll kind of move on here. And then just real quick, I just had to do it. So if you're not sure how an oral contraceptive pill works, it basically mimics your body to think that you're pregnant, right? So you're actually putting your hormones, your body through a state that shouldn't be natural. And they do that with different types of oral contraceptives. It depends what type you're taking, but the primary basis of an oral contraceptive, no matter what type you take, is to mimic a pregnancy, right? Not to help you get pregnant, but to say, hey, we're currently pregnant. We cannot allow a sperm to enter our follicle or even ovulate, right? All right, so therapies here. These are just some therapies that we do at the office. Okay, so we do peptide. We can do peptide therapy. Again, I was anticipating a couple more gentlemen to be here that this might intrigue them. This is for growth hormone, right? A lot of guys want to talk about growth hormone because that's how you increase muscle and that's how you increase weight loss. But you can do certain peptides like tesamorelin, CJC, ipamorelin, follistatin. These are all peptides that help to increase growth hormone, okay? Just have to be careful. Side effects to growth hormone, water retention, carpal tunnel syndrome, increased acne. You have to be careful with your HDLs because it can drop your HDL. So you have to look at your lipid markers. A couple other things that go along, but those are the big ones. Compounded estrogen and progesterone, as I already talked about, we work with a compounding pharmacy that we can compound these. Natural DHT blockers. So DHT is one of the biggest reasons why men and women, other than thyroid, lose their hair. So if you're having hair loss, it's the conversion of testosterone down this DHT pathway. So you can use some natural things: pumpkin seed oil, saw palmetto, diindol methane, so that's DIM, pygium, and lycopene. These are all natural DHT blockers. Okay. Aromatase inhibitors. Natural aromatase inhibitors. So this is helpful for men and women. So an aromatase inhibitor inhibits aromatization. What is that? That's the conversion of estrogen into testosterone. Okay? Conversion of estrogen into testosterone. So a lot of, my apologies. The conversion of testosterone into estrogen. Long day. Testosterone into estrogen. So you can see why men would be interested in that, because they don't want their testosterone going into estrogen. Okay? Some natural inhibitors: quercetin, chrysin, and green tea. And again, improving circulation. So when men are having issues in having ED and that's causing an issue to be able to grow their family, that's a big concern, right? So we can use nitric oxide, but at the end of the day, it's as simple as this. It's fluid dynamics, right? You have a pump, you need to put essentially water into that pump and fill up the pump, right? So that's blood flow circulation, okay? And then we do other things like PRPs, stem cells, and we're going to talk about seed cycling. So these are other things that we can do, but the PRP, stem cells, this is more in-depth. This is the minutia of it, right? I wouldn't suspect or expect to see a patient, and I would never go, okay, we're going right into PRP. We're going right into stem cells. That doesn't happen. So seed cycling. What's seed cycling? This is something you could do tomorrow if you wanted to. So there's some theory and some thought. The research isn't 100% for this, but you can use certain seeds to help support estrogen and progesterone levels. So you can go, if you think back and you're like, yeah, when I was in my teenage years, my cycle was 28 days. I want to try to get back to that. It is possible if you're still cycling, right? But you can do, 1 tablespoon of ground pumpkin and flaxseed daily for the first half of your cycle. And then you'll stop. And then maybe you're a person you don't know when you're ovulating. So you can check temperature. You can check axillary temperature, which in ovulation will increase. You can check cervical mucus. What I tell my female patients is it should look like egg yolk or egg whites. So when you crack an egg, it should look like egg whites. Okay, you should have that consistency during ovulation. And then the second half of your cycle, you do 1 tablespoon of sesame seeds and sunflower seeds. Okay? And help support your estrogen during the first half of your cycle. And the last bullet helps to support your progesterone, the second half of the cycle. Okay? First half, estrogen should be the highest. Second half, progesterone should be the highest. Okay? So I thought that would be a nice tip that people could take home and try. It's fairly easy to try. Ground them up, put them in some type of shake. Maybe you want to make them with some type of recipe. Pretty easy. Okay, healthy diet and adequate fat. Okay, Dr. Uzi Reese talks about, and the video that I saw was older when ketogenic was really, really a big thing. But it's a high-fat diet. I don't recommend it for everyone, but he talks about using a ketogenic diet, right? And having adequate fat from a ketogenic diet. So that's an aspect. And then we can get into intermittent fasting and all of that kind of stuff, but there's definitely things that we can use with our nutrition. But the biggest thing that I could tell you is keep your sugars low. I mean, these are like essentials. Keep your sugars low. Try and avoid gluten and dairy. Those are inflammatory, whether you think it's a fad thing, whether it's like, oh, that's just the trend. They are inflammatory. There's plenty of research supporting that adequately. Try to keep your carbohydrates low as well. A really good tip that again, Dr. Reese talked about, it signaled this with keeping your carbohydrates low, is for postpartum. Any female dealing with postpartum, what he does specifically, he does high amounts of vaginal progesterone, low carbohydrate diet, no calcium. Says works great for postpartum. Again, I'll repeat that in case you didn't hear it. So high vaginal progesterone, high amounts of vaginal progesterone, no calcium, low carbohydrate diet for postpartum. So keeping, again, circling back on my tangent, keeping carbohydrates low is important, okay? Healthy, I love it. I forgot I put this note on, but talking about stress, healthy lifestyle choices, right? So again, not reaching for that food for your stress, finding other alternatives, whether it's scripture, whether it's art, whether it's exercise, whether it's spending time with your loved ones, whatever it is, connect to that and find it, please, because otherwise stress will rule your life. Address adrenal health, which we talked about, getting your adrenal markers assessed, getting your thyroid assessed, using progesterone and estrogen bioidenticals, birth control pill if you're on birth control pill, taking a good solid year for transitioning and prepping when stopping that, right? Because there's a lot that be done. Natural progesterone. So if you're looking, well, what can I take naturally? I don't have to get a prescription for. I don't have to use something. So chaste tree, black cohosh, really good. Some adrenal support using adaptogens, rhodiola, ginseng, ashwagandha. There's a lot of adaptogens that are really helpful for the adrenal, but these two adaptogens have been researched pretty intensely with adrenal health, rhodiola and ginseng. Estrogen support, dong quai, pomegranate powder. These are good estrogen supports. Other herbs that help with estrogen and progesterone support, ramana root, peony root, and condopus root. I probably butchered that one. So estrogen excess. What do we do when we have estrogen excess? So if your estrogens are really, really high, fiber. Fiber helps to bind estrogen. Calcium D-glucarate helps to bind estrogen. Indole 3-carbinol helps to bind estrogen. Making sure we're improving liver function helps to bind estrogen. Polycystic ovarian syndrome, what do we do if we have that? Again, we use binders. We want to make sure we control insulin sensitivity because insulin can drive PCOS, and alpha lipoic acid, ALA. And then working on clearing toxins and metals, right? These are other things that can cause, it's another stressor on the body, right? Another stressor on the body, right? And I typically, if you're trying to conceive and you're working on this at 3 months, I would stop. That would be my suggestion. And that is it. 7:28, right on the dot. So, any questions, comments, anything, fire them at me. I'm ready. Yeah, go right ahead.
Have you heard of the Galveston diet?
Mm-mm. You say Galveston? No, enlighten me. I do not. Oh.
It's a lady that does it, and pretty much everything you said.
Yeah. And that is the diet world. I'm going to make a little tiny tweak. Instead of doing 40 grams of carbohydrates, I'm going to have you do 25, and you're going to do pomegranate juice. That's the Dr. Ross Marcagiani diet. Like that's diets.
She also, when you said make sure you get tested for the TS3 and all
Yep.
she also
Oh yeah.
she had all
Oh yeah. But you gave me something to do tonight. Now I'm gonna go. It's Galveston.
yeah.
Galveston. Okay. I got homework tonight. Yes, Soleil.
I have two questions.
Yeah, fire away.
When you talk about keeping carbohydrates low,
Yeah.
that means
Yeah, you're like, whoa, what is that? That is so arbitrary. Okay, if you're going ketogenic, 20 grams per day. Total carbs. Whoa. It's really low. Really low, right? Total carbs, 20 grams. So what's the difference between net carbs and total carbs? Fiber is not considered to be a carbohydrate when you're looking at net carbs. So you can do a ton of fiber. Your total carbohydrates will be high, but according to your net carbs, they'll be low because all that fiber is not counted for. 20 grams of total carbs on ketogenic. I typically do paleo, low carbohydrate. So paleo is no, oh wow, am I getting tired today? I say this like all the time. So paleo is no grains, so which naturally inherits gluten-free, okay? No grains, which is gluten-free, no dairy, no legumes. Beans, lentils, peanuts, soy is legumes, okay? Dairy, milk, yogurt, cheese. No grains, what's that mean? No wheat, no barley, no rye, no corn, no spelt, no amaranth, no, you name it. If it's a grain, you can't have it. But you can do potatoes, you can do white potatoes, you can do sweet potatoes, you can do yams, you can do squash. But back to your answer, Soleil, I know I'm on a tangent. Paleo, around 50 grams per day of total carbohydrates. 50 grams per day if you're doing paleo. Total. But with some of my patients, depending what their blood work looks like, I may give them a little bit of leniency. So I do go off the physiology quite a bit, but in a generality, if you're trying to stay low carbohydrate and you're getting around 50 grams per day, you're doing pretty good in my eyes. You're doing pretty good. Yeah. Did that answer your first one? Okay. Number 2, fire.
Number 2, and this isn't really the topic for tonight, so if you want to.
That's fine.
I wonder if you had any thoughts about those of us who have children in the 10 to 14-year range where everything is just going crazy with their hormones.
Yeah.
Any thoughts about that?
Yeah. Let them go run around. Put them in a sport. No. So it's important to assess and make sure, how's their focus? Is their focus good? Are they, falling into that attention deficit spectrum aspect there? But with the kids, when I see my kiddos, they got to be on I got to make sure they have good vitamin D levels. I got to make sure they have good vitamin B levels. I got to make sure they have really good fish oils for their brain, right? Support their brain, focus their brain, make sure their blood sugar levels are controlled. Because as soon as I hear that, Soleil, where they're bouncing off the wall, I go immediately, what's their nutrition look like? What's their blood sugar look like?
Well, I'm more thinking like acne, emotions.
Yep.
All over the place.
Yep. And again, I can't help it because it is just so ingrained in me, and it's the root of everything. I go back to nutrition. I go back to nutrition. I tell my patients, I want your food to be your medicine first and foremost, and then we can work on anything after that is secondary. Supplements are great. Medications can be great depending on the situation, but food has to be your medicine, and that's the foundation that everything's built off. So that's where I would go first, and then I would say, okay, well let's look at your hormones if need be, but it is somewhat to be expected, somewhat. But calcium usually when hormones are when acne, a lot of acne gut as well. That'll be another thing. All right, gut health, gut quality. But that goes back again. It always brings me back. That goes back to nutrition. You know, are you eating tons of sugar? Are you eating tons of carbohydrates? Are we going to McDonald's? Are we eating refined sugars? So again, for me, nutrition is so important. Yep.
I guess that's a important question for me. Like 14 to 16-year-old girls, my daughter's pediatrician recommended low-dose birth control for acne and for severe pain with periods.
Yeah.
They've been missing school, but it's causing anxiety, throwing up, all those things. So,
Yeah.
obviously, are you going to say like diet still?
Diet, but with that case, when they are cycling, their hormones need to be checked out. Absolutely, thyroid needs to be checked. Adrenal glands need to be checked. Even at that age, right? Because I mean, you already told me she's cycling, right?
Yeah, 14 to 16-year-old.
Yeah. They're females now. They're women. They're women. So they need to be checked out. You're not, they're not, it's not your little girl anymore, right? Well, they always will be. They always will be, right? But she's a woman now, so she needs to be checked. This is a pharmaceutical tip. It's not my preferred. For acne control, spirulactone. Spirulactone is frequently prescribed. It's not my go-to. I have several other tricks in my pocket, but if you're talking medical with the PCP, hey, I heard about spirulactone controlling acne. See what he or she says. Or you can come and talk to me. Yep.
So if we come in, how do you test for this stuff?
Blood, urine, saliva. What's that?
Easy test.
It is. Yep, it typically is very easy, except for, again, that one. But it's awesome. It's such a good test. Look at all this information you get. It's awesome. It's awesome. But, yep, it is easy. Easy. I love this. So this is like, if anyone wants to ask a question, they can. This is just me spacing out. Like, I used to be so uncomfortable up here waiting for questions, and I'll go and talk with the Amish quite a bit, and it's like, it's without question, you sit there and you wait for 5 minutes, and then a question comes in. You sit there and wait for 5 minutes, and a question comes in. So I'm like so comfortable with it now. I'm like, we could sit here all day. If something pops up, you just go ahead and let me know. It's really funny. I thought I'd just let you know that.
Well, I gotta go, but thank you very much.
Yeah, no problem. It's my pleasure. And again, if you have any interest, give the office a call. And you'll probably be speaking with this lovely lady right here. This is Erin Higgins, excuse me. We have several Erins at the office. Erin Higgins is awesome. So ask for Erin. She'll hook you up.
Another discount, right?
Well, you got to talk to her.
Thank you.
Yep.